resistant by causing vasoconstriction, or by both, and it frequently does neither. Secondary hypertension. Secondary hypertension is associated with renal parenchymal diseases such as chronic glomerulonephritis or pyelonephritis or polycystic renal disease and some other diseases, and endocrine system disorders such as pheochromocytoma, Cushing's syndrome, primary aldosteronism, and others. Vascular disorders such as coarctation of the aorta or renovascular disease, which means the narrowing of renal arteries. And it may also be associated with the use of excessive alcohol and some drugs such as, for example, corticosteroids. When we are talking about arterial hypertension, we must discuss damage of target organs. Target organs of arterial hypertension are heart, brain, eyes, and kidneys. So about heart, the heart damage in hypertension may declare itself by left ventricle hypertrophy and affecting of coronary arteries with angina pectoris, myocardial infarction development, and also sudden cardiac death. In heart damage progressing, the heart failure develops. Myocardial ischemia may appear not only due to coronary arteries affection, their epicardiac parts, but due to relative coronary insufficiency, unchanged coronary arteries, inability to supply with blood hypertrophied myocardium, and due to microvascular patting. Vessel damage. So vessels are also target organ of arterial hypertension. Vessels directly participating in high blood pressure maintenance due to total peripheral vascular resistance are themselves one of target organs. Vascular damage is characterized by involving in process retinal vessels, carotids, aorta, and also affecting of small vessels, damage of cerebral vessels, occlusions or microaneurysms, may lead to stroke. If renal arteries are damaged, it will lead to renal functions alteration. Fundi investigation allows physician to assess directly vessels changes during ophthalmoscopy. In hypertension, vessels narrow, then exposed to sclerosis, that is accompanied by microaneurysms and microhemorrhages formation, and also by ischemic damage of blood supplying organs. All these changes may be stage by stage observed on patient's fundus of eye. Brain damage. Brain damage is characterized by thrombosis and hemorrhages, hypertensive encephalopathy, and lacunar formation in brain tissue. Cerebral vessels damage may lead to changes of their walls, to development of atherosclerosis. In various stages of disease, these changes may be complicated by stroke due to thrombosis or cerebral vessels rupture with hemorrhage. Kidneys damage. As early as initial stage of disease, there is inclination to renal vessels changes, at first with some increase and then decrease of glomerular filtration rate. Long-term course of hypertension leads to nephroangiosclerosis with significant impairment of renal functions. Guys, don't speak during lecture and switch off your microphones. So long-term course of hypertension leads to nephroangiosclerosis with significant impairment of renal functions and chronic renal failure development. Renal functions reflect changes of glomerular filtration rate. If on initial stage of hypertension, glomerular filtration rate is usually normal, on later stages or in malignant hypertension, it progressively decreases. Furthermore, creatinine blood level and protein urine concentration, microalbuminuria is typical, are the indicators of kidneys involvement in pathological process. Classification of arterial hypertension. Hypertensive disease is classified according to the degree of which is determined by the level of blood pressure in untreated patients. Next classification according to the stages which are determined by the presence of diabetes mellitus, defeat of target organs, or associated clinical conditions, and the risk of developing cardiovascular complications, which includes blood pressure, associated risk factors, presence of diabetes, and associated clinical conditions. This slide is illustrating the blood pressure levels. So optimal blood pressure is systolic less than 120, diastolic less than 80. Normal blood pressure is considered 120, 129 systolic and 80, 84 diastolic. There is also high normal pressure. Systolic is 130 up to 139 and diastolic 85 up to 89. And arterial hypertension grades start from systolic blood pressure 140 and diastolic 90. So the first grade of arterial hypertension, systolic blood pressure 140, 159, diastolic 90, 99. The second grade, systolic blood pressure 160, 179 and diastolic 100 to 109. The third grade of arterial hypertension, systolic blood pressure more than 180 and diastolic blood pressure more than 110. And there is also isolated systolic hypertension when systolic blood pressure is more than 140 and diastolic pressure is normal. Next, we must discuss the factors, risk factors which influence cardiovascular risk in patients with arterial hypertension. They are divided into demographic characteristics and laboratory parameters such as sex. So men in men the arterial hypertension develops more common than in women. Age, more than 60 years, smoking, high level of total cholesterol or high level of high density lipoproteins, high level of uric acid, presence of diabetes mellitus, presence of overweight or obesity, presence of family history of premature cardiovascular diseases, family or parental history of early onset hypertension, early onset menopause in women, sedentary lifestyle is very important risk factor, social and socioeconomic factors, and the last heart rate, resting values more than 80 beats per minute. Next group of risk factors, asymptomatic hypertension, damage of target organs such as arterial stiffening. In this case, pulse pressure in older people will be more than 60. Carotid femoral pulse wave velocity more than 10 meters per second. left ventricle hypertrophy detected by ECG or by echocardiography, presence of microalbuminuria or elevated albumin-creatinine ratio, moderate chronic kidney disease, ankle brachial index less than 0.9, advanced retinopathy, and the last group of renovascular risk is established cardiovascular renal disease, or it is also called associated conditions. So it is presence of cerebrovascular diseases such as ischemic stroke or cerebral hemorrhage, coronary artery disease such as myocardial infarction, myocardial vascularization, and presence of atheromous plaque on imaging of carotid arteries. So next we must calculate the scale. This scale is designed to assess the risk of fatal cardiovascular disease for 10 years. The scale was based on data from cohort studies conducted in 12 European countries, and there are two versions of score scale for low risk countries and countries with high risk of cardiovascular diseases. So this score scale is for countries with low cardiovascular risk, and this scale for high cardiovascular risk. So this scale includes sex, age, smoking, the level of systolic blood pressure, and the level of cholesterol. So we can calculate the percentage of the risk of fatal cardiovascular events for 10 years. And then when we know cardiovascular risk calculated by score scale, and when we know the factors influencing the arterial hypertensive disease from this table, we may calculate the total risk of 10-year cardiovascular fatal events. There are 4 grades of the risk: low, moderate, high risk, and very high risk. And after this we may assess the stage of arterial hypertension of our patient. So the first stage, or uncomplicated stage, is assessed when the patient has high normal blood pressure or any degree, any grade of blood pressure, and he has only risk factors of arterial hypertension. Stage 2, we assess if patient has diabetes mellitus and the symptoms of target organs damage. From this table: asymptomatic organ damage, target organ damage. Then the third stage is established when the patient has cardiovascular diseases such as myocardial infarction or angina pectoris. He has diabetes mellitus, he has chronic kidney disease, or he has the target organ damage with its functional derangement. For example, if patient has high blood pressure and left ventricle hypertrophy, it will be the second stage of arterial hypertension. But if the patient has high blood pressure, left ventricle hypertrophy, and symptoms of left ventricle heart failure, such as dyspnea on physical activity, he will have stage 3 of arterial hypertension. So, clinical manifestations of arterial hypertension. There are no symptoms that are pathognomic for arterial hypertension. So an increase in blood pressure is the earliest and the most permanent manifestation of hypertensive disease. Complaints that force a patient with hypertension to consult a doctor are divided into three groups. Complaints caused by high blood pressure, complaints caused by vascular lesions, and complaints related to the main disease, if it is secondary hypertension. Many of patients are asymptomatic and frequently hypertension is detected occasionally. There may be neurosis signs, headaches, particularly in the mornings, nausea, flashing of front of eyes, pains in precordium, palpitation, rapid fatigability, epistaxis, hyperexcitability, irritability, and sleep disturbance. In later stages, coronary events may appear. Severity of these symptoms, in particular headaches, not always corresponds to blood pressure elevation grade. As a rule, the first complaints of the patient occur in the presence of target organ damage and associated clinical conditions, as well as in the case of accidental detection of high blood pressure at home or at doctor's appointment. On medical history analysis, it is necessary to obtain information about family history of hypertension, as well as other conditions worsening prognosis of their presence, such as diabetes mellitus, coronary heart disease, stroke, dyslipidemia. Information about duration and level of blood pressure arising, previous drug and non-pharmaceutical therapy effectiveness are important. It is necessary to elicit patients' lifestyle peculiarities, including diet, fats, excessive salt and alcohol consumption, smoking, physical activity level, excessive body mass, or obesity. On examination, we pay attention on the excessive body mass, face hyperemia, as well as pallor due to peripheral arterial spasm may be noticed. On heart examination, symptoms of left ventricle hypertrophy, such as shifting of the apex beat to the left. Case syndrome of hypertension is detected that confirmed by ECG, X-ray, and especially by ultrasound. On elevated blood pressure, there is typical pulse strain increase due to grade of which may be approximately assessed level of blood pressure. Moreover, elevated blood pressure is characterized by accent of S2 on aorta. Laboratory and instrumental methods of diagnosing. The first is ACG. ACG will detect left ventricle hypertrophy and the relative coronary insufficiency, and also left bundle branch block may develop. Cardiac ultrasound also detect left ventricle hypertrophy and left ventricle dilatation. Appearance of hypokinetic and even dyskinetic zones in the myocardium is the sign of left ventricle contractile capacity decline and development of heart failure. Diagnosis of primary hypertension depends on repeatedly demonstrating higher than normal systolic and or diastolic blood pressure and excluding secondary causes. And it is important to look for signs of hypertension mediated organ damage, target organs damage. So assessment for hypertension mediated organ damage. The first, ACG for screening of left ventricle hypertrophy, then urine albumin and creatinine ratio and blood creatinine and calculating of glomerular filtration rate, to detect possible renal diseases, fundoscopy to detect hypertensive retinopathy, more detailed screening for hypertension-mediated organ damage includes echocardiography, carotid ultrasound for determining the presence of carotid plaque or stenosis, abdominal ultrasound and Doppler studies for detecting of underlying causes of chronic kidney disease and hypertension, renal artery Doppler studies, and so on. Then we may use pulse wave velocity, ankle brachial index, which is used to screen for evidence of extremity artery disease, cognitive function testing, and brain imaging for detecting of hypertension-mediated brain damage. Principles of treatment. The main goal of treatment of patients with hypertension is to minimize the risk of developing of complications of hypertension, such as fatal and non-fatal cardiovascular events, and development of chronic kidney disease. For achievement of these goals, we need the reduction of blood pressure to target levels, correction of all modifiable risk factors such as smoking, dyslipidemia, hyperglycemia, obesity, sedentary lifestyle, and so on. Prevention, slowing down the rate of progression and or reducing the severity of target organ damage, and treatment of existing cardiovascular, cerebrovascular, and renal diseases. So lifestyle modifications includes extra rest, prolonged vacations, moderate weight reduction, dietary restriction of natri, and so on. Smoking, stop smoking, and about core drug treatment. So we drug treatment strategy. So monotherapy nowadays is used in patients with low risk degree of low risk and grade first of hypertension. We may choose angiotensin converting enzyme blocker or angiotensin receptor blocker or calcium channel blocker or diuretic for monotherapy. But if patient has moderate and high risk and grade 2 or grade 3 of arterial hypertension, we will start our therapy from dual combination of angiotensin converting enzyme blocker with calcium channel blocker or with diuretic. If this therapy is not appropriate, is not successful for this patient, we will suggest triple combination, all three drugs, and so on. And beta blockers. We consider to use beta blockers at any treatment step when there is a specific indication for their use. For example, presence of angina pectoris, heart failure, or past myocardial infarction, cardiosclerosis, or in case of presence of different types of arrhythmia or in young women. So this is all information about arterial hypertension, and now we will focus on atherosclerosis and coronary artery disease. So atherosclerosis, a form of arterial sclerosis characterized by patchy subintimal thickening, so-called atheromes of medium and large arteries, which can reduce or obstruct blood flow. the prevalence of clinical manifestations of atherosclerosis is in general increases in postmenopausal women and begins to approach that in age-matched men. About etiology, two main hypotheses have been proposed to explain the pathogenesis and etiology of atherosclerosis. They are the lipid hypothesis and the chronic endothelial injury hypothesis. So we will talk about this hypothesis. Atherosclerotic plaque consists of accumulated intracellular and extracellular lipids, smooth muscle cells, connective tissue, and glycosaminoglycans. The earliest detectable lesion of atherosclerosis is the fatty streak consisting of lipid-laden foam cells, which are macrophages that have migrated as monocytes from the circulation into the subendothelial layer of the intima, which later evolves into the fibrosous plaque consisting of intimal smooth muscle cells surrounded by connective tissue and intracellular and extracellular lipids. So this picture illustrates atherosclerosis timeline from fatty streaks up to formation of fibrous plaque and complicated lesion of the plaque, it means rupture of the plaque with thrombus formation. So some plaques covered by a thin fibrous cap may undergo spontaneous rupture. These plaques are unstable or vulnerable and are more closely associated to the ischemic heart disease, also is known as coronary heart disease. So coronary artery disease or ischemic heart disease. Myocardial ischemia occurs when the myocardial oxygen demand exceeds the ability of its delivery with the blood flow through coronary arteries. The main mechanisms of ischemia: decrease in the coronary reserve, the ability to increase coronary blood flow when increasing the metabolic needs of myocardium, and the second, primary reduction of coronary blood flow. The myocardial oxygen demand is determined by three main factors: left ventricle wall tension, heart rate, and myocardial contractility. The main modifiable risk factors of chronic heart disease: hypercholesterolemia, arterial hypertension, diabetes mellitus, smoking, low physical activity, obesity, and non-modifiable risk factors of coronary artery disease are male gender, age, and hereditary. The higher the value of each of these indicators, the higher the consumption of oxygen by the myocardium. The amount of coronary blood flow depends on three main factors: resistance of coronary arteries, cardiac contractions rate, perfusion pressure, the difference between diastolic pressure in the aorta and diastolic pressure in the left ventricle. Classification of ischemic heart disease. The concept of ischemic heart disease includes acute, transient, unstable, and chronic stable conditions. Currently, acute ischemic heart disease is considered an acute coronary syndrome. Acute coronary syndrome is a term that refers to a period of exacerbation of coronary heart disease when any group of clinical signs or symptoms suggests an acute myocardial infarction or unstable angina. Includes the concepts of acute myocardial infarction with ST segment elevation, and myocardial infarction without ST segment elevation on ACG or non-ST segment elevation myocardial infarction. Myocardial infarction diagnosed by changes in enzymes and other biomarkers, late ECG signs, and unstable angina. So the term acute coronary syndrome was introduced into clinical practice when it became clear that the use of certain active methods of treatment, in particular thrombolytic therapy, should be resolved quickly, often before the final diagnosis of myocardial infarction. The chronic form of ischemic heart disease includes stable angina, indicating the functional class according to the classification of the Canadian Cardiovascular Society, vasospastic angina, microvascular angina, post-infarction focal cardiosclerosis, and pain-free myocardial ischemia. According to European guidelines of coronary artery disease, the disease is considered to be chronic, most often progressive, and hence serious even in clinically apparently silent periods. The dynamic nature of coronary artery disease process results in various clinical presentations which can be conventionally categorized as either acute coronary syndromes and chronic coronary syndromes. So the most frequently encountered clinical scenarios in patients with suspected or established chronic coronary syndrome are: the first, patients with suspected coronary artery disease and stable anginal symptoms with or without dyspnea. The second group, patients with new onset of heart failure or left ventricle dysfunction and suspected coronary artery disease. The next group, asymptomatic and symptomatic patients with stabilized symptoms less 1 year after an acute coronary syndrome, or patients with recent revascularization. The fourth group, asymptomatic and symptomatic patients more than 1 year after initial diagnosis or revascularization. The fifth group, patients with angina and suspected vasospastic or microvascular disease. And the sixth, asymptomatic subjects in whom coronary artery disease is detected at screening. So remember, all of these scenarios are classified as chronic coronary syndromes, but involve different risks for future cardiovascular events, for example, death or myocardial infarction, and the risk may change over time. Development of an acute coronary syndrome may actually destabilize each of these clinical scenarios. The risk may increase as a consequence of insufficiently controlled cardiovascular risk factors, suboptimal lifestyle modifications and or medical therapy, or unsuccessful revascularization. Alternatively, the risk may decrease as a consequence of appropriate secondary prevention and successful revascularization. Hence, chronic coronary syndromes are defined by the different evolutionary phases of chronic artery disease, excluding situations in which an acute coronary artery thrombosis dominates the clinical presentation. For example, acute coronary syndrome. So for the first, we will talk about chronic artery disease, coronary artery disease, and about angina pectoris. So angina pectoris is a clinical syndrome due to myocardial ischemia characterized by precordial discomfort or pressure, typically precipitated by exertion and relieved by rest or sublingual nitroglycerin. Pathogenesis of angina pectoris. It is based on three mechanisms: atherosclerotic coronary arteries lesions and inability to provide increased needs, fixed coronary obstruction. It is stable angina. The next, transient vascular thrombosis, platelet aggregates. It is unstable angina. And the third, decreased coronary blood flow due to spasm or increased coronary arteries tone, dynamic obstruction. The morphological substrate of angina is almost always atherosclerotic narrowing of the coronary arteries. Atherosclerosis, thickening and compaction of the walls of the arteries, characterized by damage to large arteries, and occurs in patients with coronary heart disease. Angina appears during physical exertion or stressful situations if there is a narrowing of the lumen of coronary artery by at least 50–70%. The greater the degree of stenosis of coronary arteries, the more severe as a rule angina pectoris. The severity of angina also depends on the location and extent of stenosis, their number and the number of affected arteries. The degree of stenosis, especially eccentric, can vary depending on changes in the tone of smooth muscles in the area of atherosclerotic plaque, which is manifested in changes in the tolerance of physical activity. In rare cases, angina can develop in absence of visible stenosis in the coronary arteries, but in such cases, angiospasm or disorders of endothelial function of the coronary vessels almost always occur. Clinical picture of angina pectoris. Diagnosis of angina is a clinical diagnosis. So we must carefully perform questioning of our patient and ask many questions about his pain syndrome. So the nature of the pain syndrome. This syndrome is paroxysmal discomfort or pressing, squeezing, this deep and dull pain. The attack can be described as tightness, heaviness, lack of air. The localization of and radiation of pain. The most typical localization of angina pain is behind the sternum, retrosternal, or on the left edge of the sternum. Typical irradiation to the neck, lower jaw, teeth, intrascapular space, less often in the elbow or wrist joints, masted processus. The most typical, the left-sided irradiation. Duration of attack is from 1 minute up to 15 minutes, more common from 2 to 5 minutes. Causes of occurrence of attack. Attack is connected with physical or emotional stress. Factors that eliminate the attack: sublingual nitroglycerin or load termination. Maybe attacks at rest. The same characteristic except of the connection with physical activity, but attacks can be longer, up to 20 minutes, and the effect of nitroglycerin is less pronounced. General examination of patients with angina pectoris. So we may detect symptoms of atherosclerosis, such as tendon xanthomas or corneal lipoid arch. We may detect systolic murmur of mitral regurgitation in ischemic papillary muscle dysfunction, or stenotic murmur over the carotid arteries due to atherosclerosis of carotid arteries. Intermittent claudication with lesions of the iliac arteries with Leriche syndrome, diagnosis of other diseases that occur with angina syndrome, such as aortic heart disease or aortic aneurysm. So this is corneal degenerations, arcus senilis, so-called arcus senilis. It is an age-related hazy gray line of fatty degeneration which encircles the cornea just inside the limbus and may be a symptom of hyperlipidemia, high level of cholesterol. Xanthelasms, deposits in the angle of the eye. So grading of angina pectoris according to Canadian Cardiovascular Society classification. There are 4 grades of stable angina. The first grade, ordinary physical activity does not cause symptoms, and attacks of angina pectoris appear during hard, fast, or long-term exertion. The second grade, comfortable at rest, ordinary physical activity causes symptoms. Angina appears on walking or fast stair climbing, going uphill after meals in cold weather, against the wind and emotional exertion. Walking in distance more than 100-200 meters on flat place or stair climbing more than one stair will develop angina pectoris attack. The third grade means comfortable at rest and less than ordinary activity causes symptoms. Walking on flat place or stair climbing less than one stair will develop angina pectoris attack. And the fourth grade, symptoms may present at rest, inability of any kind of physical ability without discomfort. Clinical variants of angina pectoris. Patients with a new onset, less than 2 months, angina that is severe and or frequent, more than 3 episodes per day. Patients with accelerating angina, those with chronic stable angina who develop angina that is distinctly more frequent, severe, prolonged, or precipitated by less exertion than previously. Early post-myocardial infarction angina and acute coronary insufficiency attacks. So this is clinical variants of unstable angina pectoris. Diagnosis of angina pectoris is based on a characteristic complaint of chest discomfort brought on exertion and relieved by rest, and diagnosis may be confirmed if reversible ischemic ACG changes are seen during a spontaneous attack. A wide variety of changes may appear, but the most common are ST segment depression, maybe ST segment elevation, decreased air wave, intraventricular or bundle branch conduction disorders, and arrhythmias such as ventricle extrasystoles. Between attacks, the ACG at rest is normal in about 30% of patients with a typical history of angina pectoris, even with extensive 3-vessel coronary artery disease. So this is ACG typical changes of ST segment. The most typical is horizontal depression of ST segment. It may be accompanied with positive T or negative T. It may be downsloping depression of ST segment, also accompanied by negative T or biphasic T. The next instrumental method of diagnosing of angina pectoris, exercise stress ACG testing, because the diagnosis of angina is usually primarily based on the patient's history. Exercise testing in patients with typical symptoms is generally used to determine functional and ACG response to graded stress. ACG symptoms indicating the appearance of myocardial ischemia, horizontal or oblique displacement of ST equal to or greater than 2 millimeters. So this is depression of ST segment more than 2 millimeters. One box is 1 millimeter. The next method, long-term ambulatory ACG monitoring. Indications for long-term ambulatory ACG monitoring for angina are: the first, diagnosis, verification and assessment of the severity of stable angina, assessment of the grade of angina, assessment of the association of episodes of transient myocardial ischemia in atypical presentations, identification and assessment of the nature of rhythm and conduction disorders to identify ischemic arrhythmias that occur during episodes of transient ischemia, and identification of possible contraindications for the appointment of anti-anginal drugs. Next method, coronary angiography, which documents the extent of anatomic coronary artery obstruction. Coronary angiography findings parallel post-mortem findings, but the extent and severity of disease are usually underestimated. Vessels as small as 1 millimeter may be visualized with high-quality imaging. Coronary artery disease is recognized by narrowing, beading, and occlusion of the vessels. Obstruction is assumed to be physiological significant when the luminal diameter is reduced more than 70%, which correlates well with the presence of angina pectoris. Lesser degrees of obstruction are unlikely to result in ischemia, unless spasm or thrombosis. So this is example of coronary angiography, and by the points are detected the atherosclerosis and narrowing of coronary arteries. Laboratory methods. It is recommended to conduct a blood test to assess the level of lipids, of cholesterol, including the level of total cholesterol and the level of low-density lipoprotein cholesterol and triglycerides in the blood, in order to identify the risk factor and, if necessary, correct the therapy. And if there are clinical grounds, we must screen for diabetes mellitus. Principles of treatment of angina pectoris. For the first, impact on risk factors. Impaction includes dietotherapy, treatment of arterial hypertension, smoking cessation, lipid-lowering therapy. To prevent cardiovascular complications, all patients with stable coronary heart disease are recommended to prescribe statins at the maximum tolerable dose until the target level of low-density lipoprotein cholesterol is reached. The target level is less than 1.4 millimole per liter, or it is reduced by 50% from the initial level. Then we must treat diabetes mellitus if it is present, and physical training. Drug treatment. The aims of pharmacological management of chronic coronary syndrome patients are to reduce angina symptoms and exercise-induced ischemia, to prevent cardiovascular events, immediate relief of anginal symptoms, or the prevention of symptoms under circumstances likely to elicit angina is usually obtained with rapidly acting formulations of nitroglycerin. So we may use anti-ischemic drugs, and anti-ischemic drugs includes for the first nitrates. They are divided into two groups: short-acting nitrates for acute effort angina and long-acting nitrate formulations for long-term treatment. The next group are beta blockers for the treatment of stable angina, and beta blockers are considered as the drug of choice for the treatment of stable angina. They are also divided into two groups: cardioselective and non-cardioselective beta blockers. The next is calcium antagonists. They are divided into two groups also: dihydropyridine drugs and non-dihydropyridine agents. Dihydropyridine drugs mainly affect the tone of arterioles. They reduce afterload, improve blood flow and oxygen delivery in the ischemic area of the heart, and at the same time they can increase heart rate and reduce systemic blood pressure. Non-dihydropyridine agents act primarily on the myocardium. They reduce heart rate, inhibit myocardial contractility and atrioventricular conduction, and have an antiarrhythmic effect. The next principle of treatment of chronic heart syndromes: treatment for prevention of cardiovascular complications. It includes applying of antithrombotic therapy and renin-angiotensin-aldosterone system blockers. These drugs can reduce motility, myocardium infarction, stroke, and heart failure among patients with left ventricle dysfunction, previous vascular disease, and high-risk diabetes mellitus. So that's all about angina pectoris, and now we'll continue talking about myocardial infarction. So myocardial infarction is ischemic myocardial necrosis, usually resulting from abrupt reduction in coronary blood flow to a segment of myocardium. Etiology and pathogenesis of myocardial infarction. Causes are coronary thrombosis. This cause is in more than 90% of patients with acute myocardial infarction. An acute thrombus, often associated with plaque rupture, occludes the artery previously partially obstructed by an atherosclerotic plaque that supplies the damaged area. Myocardial infarction is rarely caused by arterial embolization, for example in mitral or aortic stenosis or infection endocarditis, and very rare due to coronary spasm. Myocardial infarction has been reported in patients with coronary spasm and otherwise normal coronary arteries. Very rare cause. So nowadays we have a clinical classification of myocardial infarction. According to this clinical classification, there are 5 types of myocardial infarction. Myocardial infarction of type 1 is caused by atherothrombotic coronary artery disease and usually precipitated by atherosclerotic plaque disruption. Myocardial infarction type 2, pathophysiological mechanism leading to ischemic myocardial injury in the context of mismatch between oxygen supply and oxygen demand due to, for example, non-atherosclerotic coronary dissection, or due to vasospasm, or due to imbalance between oxygen supply and oxygen demand. Type 3. The detection of cardiac biomarkers in the blood is fundamental for establishing of the diagnosis of myocardial infarction nowadays. However, patients can manifest a typical presentation of myocardial ischemia and myocardial infarction, including presumed new ischemic ECG changes or ventricular fibrillation, and die before it is possible to obtain blood for cardiac biomarkers determination. Or the patient may succumb soon after the onset of symptoms, before an elevation of biomarkers values has occurred. So such patients are designed as having type 3 of myocardial infarction. Type 4. Myocardial infarction associated with percutaneous coronary intervention. Stent, scaffold thrombosis associated with percutaneous coronary intervention will be type 4B myocardial infarction. Restenosis associated with percutaneous coronary intervention type 4C myocardial infarction, and the fifth type of myocardial infarction associated with coronary artery bypass grafting. Also, myocardial infarction is classified according to the stage: superacute, acute, subacute, reduction stage, and scar stage. According to the size of the necrotized focus, it may be micro, non-Q wave myocardial infarction, and macrofocal Q wave myocardial infarction. According to the depth of the necrotized focus, subendocardial, subepicardial, intramural, and transmural myocardial infarction. According to localization of necrotized focus, it is anterior, posterior, lateral wall of left ventricle, apical myocardial infarction of the left ventricle, anteroseptal or right ventricle myocardial infarction, and atrial myocardial infarction. The next classification: myocardial infarction with ST segment elevation ECG, myocardial infarction without ST segment elevation ECG, or it is also called non-ST segment elevation myocardial infarction. Clinical picture. The outstanding Russian physicians Obraztsov and Strazheska were the first to describe the clinical picture of myocardial infarction in 1909. They differentiated between three typical variants of its course, namely anginosus, asthmatic, and abdominal or gastrologic forms. For the first, the most typical anginosus form of myocardial infarction. The anginosus form occurs most frequently. Clinically, it is characterized by the pain syndrome, pressing pain behind the sternum or in the region of the heart, develops like an angina pectoris. As a rule, pain radiates into the left shoulder, left arm, less frequently into the right shoulder. Pain is sometimes so severe that cardiogenic shock develops, which is characterized by the increasing weakness and adenomia, paleness of the skin, cold sweat, and the decreased arterial pressure. As distinct from angina pectoris, pain in myocardial infarction is not removed by nitroglycerin, and persists for longer time, from 30 to 60 minutes and for several hours. Prolonged pain in myocardial infarction is termed as status anginosus. Atypical forms of myocardial infarction. The first is asthmatic form, begins with an attack of cardiac asthma and lung edema. The main syndrome is either absent or weak. The abdominal form of myocardial infarction is characterized by pain in the abdomen, mostly in the epigastric region. The pain may be attended by nausea, vomiting, constipation. This form of the disease occurs mostly in infarction of the posterior wall of left ventricle. So you must remember that all patients with a diagnosis of acute stomach need to perform an electrocardiogram, ECG. Further observations have shown that the disease has considerably great number of clinical signs. Myocardial infarction may sometimes begin with a sudden heart failure or collapse, various disorders in the cardiac rhythm or heart block, while the pain syndrome is either absent or very weak. It is so-called painless form, and it is especially characteristic for patients with diabetes mellitus. Once more, a typical form is cerebral form of myocardial infarction is characterized by disorders in the cerebral circulation of various intensity. It should be taken as a rule for any sudden appearance of cerebral disorders, it is necessary to record an ECG. General examination. On examination, the patient is usually in severe pain, restless and apprehensive, with pale, cool, diaphoretic skin. Peripheral or central cyanosis may be apparent. The pulse may be threadly, pulsus filiformis, and the blood pressure is variable. Although many patients initially manifest some degree of hypertension, unless cardiogenic shock is developing. Heart sounds are usually somewhat distant, diminished. The presence of the fourth heart sound is almost universal. Soft systolic apical murmur as a reflection of papillary muscle dysfunction may occur. At initial evaluation, a friction rub or more striking murmurs suggest pre-existing heart disease or another diagnosis. Detection of friction rub within a few hours after onset of myocardial infarction symptoms is distinctly unusual and might suggest acute pericarditis rather than myocardial infarction. Friction rubs, usually evanescent, are common on the second or third day of Q-wave infarction. The diagnosis of myocardial infarction is established on the basis of clinical picture, taking in account the history of the disease and life of the patient, ECG criteria, and biochemical markers, detection of cardiac troponins. Cardiac troponin E, I, and T are components of the contractile apparatus of myocardial cells and are expressed almost exclusively in the heart. ECG in myocardial infarction. ECG examination is especially important. It establishes the presence of myocardial infarction, also some important details of the process, such as localization, depth of the process, and the size of affected area. So there are three zones of myocardial damage in acute myocardial infarction. which may be detected by ACG. Necrotic zone, ischemic myocardial injury zone, and zone of ischemia. So we will discuss transmural or Q wave infarction. So this infarction is characterized by negative T, which considers the zone of ischemia, ST elevation and developing of monophasic curve, which considers the damage, the injury of heart muscle. Then formation of pathological Q wave, which considers the necrosis of myocardium. Pathological Q wave is characterized by increased depth and width of Q wave. The next ACG change is called discordance of the offset ST. ST segment in leads opposite to the localization of infarction will be depressed. And the next change is dynamics, because there are several phases of acute myocardial infarction, and we may detect these phases by the series of ACG testing. So this is the dynamics or stages of myocardial infarction. So the first stage, the stage of ischemia, it is detected by high pointed or so-called coronary T wave. The next stage, pre-acute stage, which lasts for 3 days. It considers to ischemic injury of myocardium, and ACG symptom is ST elevation with developing of monophasic curve. The next stage is acute stage. It lasts for 3 weeks, and it is characterized by formation of pathological Q wave and negative T wave. The next stage, subacute stage, which lasts for 3 months. It is characterized by presence of pathological Q wave, by depression of ST segment to the easyline and negative T wave. And the last scar stage, which lasts for the rest of the life, it is characterized by presence of pathological Q wave, ST segment is on easyline, and T wave may be positive, may be negative, or may even absent. Localization of myocardial infarction. So by ACG we may detect the localization of myocardial infarction. So we need 12 leads ACG. If we see the pathological changes in the first, so for our class on myocardial infarction, you must learn this table. So if we see pathological changes in the first standard lead, augmented alveoli and left chest leads, it considers the myocardial infarction of anterior wall of left ventricle. If we see changes only in V1, V2, this is anterior part of intraventricular septum. If we see pathological changes in the first standard lead, alveoli and V5, V6, this is lateral wall of left ventricle. If we see pathological changes in the second, third standard lead and AVF, this is posterior wall of left ventricle. And if we have additional leads, high R in V1, V2, this is posterior wall of left ventricle. So this is example of anterior wall infarction. So we see elevation of ST segment in the first standard lead, in AVL, and in V2, V3 and V4. So this is elevation of ST segment and very high and pointed T wave. Example of anterior part of intraventricular and anterior infarction. So we see elevation of ST segment in V2, V3, infarction of the inferior wall and lateral wall of left ventricle, elevation of ST segment in the second, in the third standard lead, AVF and V5 and V6. Inferior infarction, acute stage of myocardial infarction, because we see pathological Q in the third standard lead and elevation of the ST segment in the third standard lead, AVF, V5 and V6. And this ACG illustrates such symptom as discordance. So discordance means that in the leads considering the necrosis, we will detect elevation of ST segment. And in opposite leads, for example, for the third lead, the first standard lead is considered to be opposite, we detect depression of ST segment and negative T. Discordance means vice versa, changes in opposite leads. Blood tests. So routine laboratory examination reveals abnormalities compatible with tissue necrosis. Thus, after about 12 hours, the erythrocyte sedimentation rate is increased, double BCs is moderately elevated, and differential white blood cell count reveals a shift to the left. But the most sensitive for myocardial necrosis is detecting of myoglobin and contractile proteins, troponin T and troponin E. They are released by infarcted myocardium. Troponin T and troponin E appear to be highly sensitive markers of myocardial injury and may replace other biochemical biomarkers. Troponins are released in some patients with unstable angina, and activity level predicts further adverse events. Principles of treatment. Treatment is designed to relieve distress, reverse ischemia, limit infarct size, reduce cardiac work, and prevent and treat complications. Myocardial infarction is an acute medical emergency, and outcome is significantly influenced by rapid diagnosis and treatment. So for the first, we must give aspirin for the patient if it is not contradicted. Then we must apply oxygen, we must apply morphine, then thrombolytic therapy. Thrombolytic therapy is most effective in the first few minutes and hours after one set of myocardial infarction, requiring rapid diagnosis. Greatest benefit occurs within 3 hours, but effectiveness up to 12 hours has been demonstrated. Thrombolysis should be considered in patients with ST segment elevation in 2 or more continuous leads, in patients with typical symptoms in whom bundle branch block obscures evidence of infarction, in those with strictly posterior myocardial infarction, and in the occasional patients presenting with giant T waves. Concomitant antithrombotic therapy. The use and route of heparin therapy depends on the thrombolytic drug used and the thrombolytic embolic risk. Then we must use drugs to reduce cardiac work. Cardiac performance after recovery depends largely on the mass of functioning myocardium surviving the acute episodes. Reduction of myocardial oxygen requirements by decreasing afterload with vasodilatators or reducing heart rate and contractility beta blockers reduces the size of myocardial infarction. And the last, primary percutaneous transluminal cardiac angioplasty. Using this method as initial treatment is at least as effective as in certain catheterization laboratories, may be modestly better than thrombolysis in reducing infarct size, additional cardiac events and motility in patients with elevated ST segment myocardial infarction. How to choose a method of reperfusion therapy? If treatment can be started in the first 3 hours of segment ST elevation myocardial infarction, then the effectiveness of thrombolytic therapy and balloon angioplasty is the same, but at later time balloon angioplasty has the advantage. Optimally, thrombolytic therapy should begin no later than 10 after the first contact of the patient, 10 minutes with ST elevation myocardial infarction with a doctor, and balloon angioplasty with 90 minutes. When restoring coronary blood flow